everyone. This is the study guide, I guess. We're going to go through, and hopefully the audio is coming through, as well as the visuals for the PowerPoint. So we're just going to go through pretty much just the summaries that I have already posted, with the exception of week 4. So this exam is 50 questions. It's multiple choice, and it covers modules 1 through 4. So the work that you're doing this week on module 5 with groups will not be tested on this exam. That will be on the next exam. So we're going to go through the first 4 modules, and I'm going to start, it's pretty much in order. And the first module covers the DSM-4 versus the DSM-5, and some of the comparisons that you made, such as the difference between using axes, and now with DSM-5 we no longer use the axes. There is let's see, axes 1 through 5. We have axes 1 through 4 here, and just so that you have an idea of what goes on which axis, that's going to be important to know. And what I'm going to do to keep this review as short as possible, to try to avoid upload issues and long wait times for the upload, is I will try to keep it as short and to the point as possible, hopefully without sacrificing any information. But it's not intended to be like a comprehensive review of all of the concepts, but I want to touch on what I think are important concepts for the exam, and I think that that's probably what you want as well. So for the axes, so if you know what they are, first of all, the axis 1, which would be your clinical disorders, those would be psychiatric disorders, okay? So axis 2 are the personality disorders, and when we use DSM-4, the mental retardation, which is now intellectual disability. Axis 3 are any medical conditions that they have and are relevant, and then axis 4 are psychosocial and environmental problems. So then moving to the next one, which is right up here, axis 5 is the global assessment of functioning, or the GAF or GAF. So if you would know where these lie, know the numbers, like it's a 0 to 100 scale. 100, anywhere from 91 to 100 means no symptoms. You're probably not going to be seeing these patients in your practice, in your psychiatric practice anyway. So this is to measure the degree of impairment that the psychiatric symptoms have on the patient. So if you start getting down here, and there is some subjective and some objective information to consider when you're doing this, but so if you're down here somewhere between 50 and 40, you know that the person is probably pretty sick. So know that 61 to 70 mild, moderate, and serious, and then 30 and below indicates that the patient is very sick. So just know the numbers. They usually go in these 10 increments of 10, and mild, moderate, serious, and then worse than that. And so again, on the exam, there will be, it's multiple choice, but there will be scenario questions. So if you had to assign a GAF score to a patient in a scenario, you would probably want to be able to do that. Got a sticky mouse here. Okay. And then moving on to the DSM-5, we use the HUDAS scale now. I don't really see it used in practice. I'm not sure if maybe some of you do. We just aren't really using anything, and it does not seem to be a requirement at this point for reimbursement. So I've yet to see that universally applied. So one of the other objectives was to demonstrate an understanding of that should be ICD-10, and other types of coding. So there are 10 classifications this is not going to be significant to know for the exam. It is significant, however, for practice, but again, we want to review the important things that will be on the exam. Discuss the use of legal documentation in relation to assessment planning and evaluation. Know that it is an important part of care. It is necessary to protect you from liability, and it is also necessary for justifying reimbursements as well. So it is a very important, and when we get into Module 3, I think, is when we will talk about the different types of notes. The SOAP note, SOAPy note, and SOAPier note. Oh, nope, it's here. Sorry. So SOAP notes, I think everyone is familiar with. SOAP is the subjective, objective, and assessment and plan. So if you want to add the I and the E and even the R, be familiar with what would be examples of each. You know, I think we're all very well versed in a SOAP note. If we wanted to include implementation and evaluation and response to diagnostic process and intervention, sometimes we don't always have the opportunity to do this, especially in outpatient. But if you were outpatient or inpatient, inpatient, you may be able to do this. You know, even if it's something as simple as redirection, or you know, if somebody's on the unit and they responded well to some kind of redirection or something like within a group setting, you may be able to document all three of these extra things. So moving on to the actual psychiatric assessment. If you have Robinson, the little tiny books for Robinson, or the small Carlat book, either one has the information that you need. I believe that the latest is Carlat. But the information did not change that much. You can also use your Kaplan and Sadek book to find out which elements are necessary for the assessment. And this goes down through. You want identifying information and a chief complaint. You want your HPI. This should be where you are justifying your diagnosis. This is a subjective portion of your documentation and of the assessment. You want to use subjective terms. You want to use terms that reflect what your patient is reporting, or collateral information. So you don't want to put any assessment data in there. So you don't want to put anything like there is no evidence of, or anything that would be objective. So you could always use patient denies to make that subjective. But it is going to be primarily their report or the report of others that gives you some indication as to how to proceed with the assessment, and then making a diagnosis based on the subjective and the objective portions. The psychiatric history, substance use history are next. Substance use history is always a good idea to get a pretty comprehensive and thorough substance use picture if they do have a history of that. For instance, what is their drug of choice? When was the first use? When was the last use? If there are different contexts in which the use occurs, that is all very good information. First and last use, drugs of choice are actually very important. Medical history, especially if it's relevant, head injuries, seizure disorders, things like that, and family history. That's family history, family psychiatric history, and maybe any family history of pertinent medical diagnoses as well, especially if there's like some neurological issues or things of that nature. Psychosocial, a lot of stuff falls under psychosocial. So you have developmental, social, occupational, educational, cultural, spiritual. All of these things sort of fall under that area. And I will say that primarily the questions are focused on a lot of psychosocial and like understanding what goes under psychosocial and what those types of things are. What does that actually mean? And communication, therapeutic techniques, getting a little ahead of myself just because those are in later modules, but I wanted to bring it up here because I know that that is one of the elements that is very well represented on the exam. Also, some scales. Be familiar with some of the more widely used scales, such as CAGE, the PHQ, and the Holmes. Now, this is a stress scale, this life stress inventory. It's very popular. I don't know how many folks use this. It's probably better as a screening tool because certainly somebody could have a lot of these things and not feel significantly stressed. But it's a good idea to have, just like the GAF, have some idea of what the scores mean. So from 1 to 43, there is a value assigned, and that is over here. This value is over here. So death of a spouse, that is the most stressful thing that someone can go through, and then it just sort of goes down. So have an idea of what is really stressful and what is not as stressful. Again, you're going to need to apply some of this knowledge to some scenario questions. Before you can diagnose anything psychiatrically, technically you must rule out a substance-induced or a medical cause for the psychiatric symptoms. That follows every diagnosis in the DSM. If you get down to the end, you know, that is actually one of the criteria, that these symptoms are not, I forget the exact wording, but these symptoms are not better accounted for by or caused by the effects of a substance or a medical disorder. So you really need to make sure medical and substance are ruled out before you give them a primary psychiatric diagnosis. And these are some of the more prominent ones that we see. These are the things, you know, CNS trauma or disease, sleep disorders, anemia, tumors, hormonal imbalances, infection, and nutritional deficiencies, as well as electrolyte imbalances. If you remember back to Psychopharm, one of our scenarios was the patient with a new onset of mania and had a low sodium level. So just that was thrown in there just to make things a little bit more fun. The mental status exam is the objective portion of your assessment. So this is the way that it should be organized. So you may not think that organization is all that important, but it actually is. It really is just standardized for ease of use, ease of reading, understanding, and these are generally the way that you will record your findings. So their appearance, and again in Carlat, Robinson, or in Kaplan, examples of these things, of each of these little subsections will be in those books. So you want to comment on each one of these. Appearance, their behavior, their speech. Their speech often gives rise to evidence of what their thought process is like. Oh, here, yeah, I have it here. So that's important. Also, it can give you an idea of what their attitude or how likely it will be that they will be cooperative and responsive to treatment. It can tell you a lot. So there's a lot of descriptions that you could use for speech. And the next is affect and mood. Remember, affect is the outward display of emotion. That is objective. But then you can also include mood here. But you should qualify it with something that says, you know, the patient states mood as, even though this is an objective portion of your assessment. But you don't want to leave mood out. Affect should be described in terms like, because there are different domains of the affect. You have range, you have type, you have congruency. So you want to think about all of the different aspects of affect that you need to be assessing and documenting. Thought content That's what they are thinking. So that is any kind of ideation, delusions, and their thought process or thought form. That is how they are forming their thoughts. And again, that can be assessed through speech. So you want to think about things like circumstantiality, tangentiality. You know, are there associations really loose? Those terms that go with that are going to be very important. Cognition covers a lot of things as well. Judgment and insight go there. Memory goes under cognition. You can test for judgment and insight by asking some questions, such as if you found an envelope and it was stamped on the ground, what would you do with it? If you smelled smoke and you were in the movie theater, what would you do? That's something that you can test for judgment. Insight is how well do they understand their illness, and if they even believe that they are ill at all. And memory, short-term and long-term. Thought process, also think about if they have the ability to have abstract thought. If they do not, if they're not able to abstract, that would be indicated by incorrect or inability to interpret proverbs. That's a very quick way to test for that. If they cannot abstract, if their abstract thinking is not intact, then it's usually called concrete. They have very concrete thought process. So now we're moving into, so that was sort of module 1 and 2 put together because they were fairly similar, fairly close in content matter. So we want to go through and understand and remember what these psychosexual stages are, comparing that to, which you did in discussion, comparing that to Erickson's developmental stages. So there's the 5. So that's important to know, with their ages and what the tasks are that go along with those, and what that would look like if you had, for instance, I think the discussion question was very similar to the things that you will need to know for, there's a couple of questions on that. This is not an area that has a lot of questions, but the different categories of awareness, the unconscious, the preconscious, and the conscious. So each of these are the major theories. So there are the psychosexual stages of development, and then there are these categories of awareness, and then Freud also had a theory on personality. And that has 3 distinct but interrelated systems, and that is the id, the ego, and the superego. I think we've all, even in pop culture, you hear about the id, the ego, a little bit less than the superego, but you can think about it, you know, this is, the id dominates your infant behavior. If you just think about somebody that is just really hedonistic, is only interested in things that bring them pleasure. So it's sort of that aggression is also associated with the id. You know, there's just not a lot of self-control, not a lot of impulse control if the person is dominated by this area. So the ego is sort of the moderator between the id and the superego, and operates in reality, really. And your superego is your conscience. So that's the thing that's always sort of motivating you to do what you think is good and what you think is right, despite what your id may want. You're going to do things that don't necessarily bring you pleasure because that's what we do. There are also some defense mechanisms. Understanding what those are, you can see a fairly comprehensive list in Kaplan and Sadek. All of them are unconscious, but suppression. Suppression is actually one of the healthier or a healthy defense mechanism. We all strive for that. But defense mechanisms generally deny, falsify, or distort reality. And it is that degree of distortion, according to Freud, that has, and now that when we talk about personality or a personality construct, as we used to classify them on Axis 2, it is the degree. Like, so someone can have traits. I mean, we all have traits across all of the categories of personality disorders, but it is actually the degree. If somebody is actually disordered, it's causing significant distress and disruption in relationships. Let's see, I think I left this as blank. This is not something that is crucial, other than to know that those stages, the developmental stages for both Freud and Erikson. Keeping with Freud and his theories inform psychoanalysis, or a little lesser degree psychodynamic therapy. And the concept of transference and countertransference are crucial here. The experience of countertransference is important to understand. It doesn't matter what you're practicing, what type of therapy you are using. Being aware of countertransference can give you some indication of their pathology, what it actually is, and how severe it is. It should be considered a tool in therapy. You know, if you have somebody that you're having a lot of negative countertransference toward, you may be able to understand why the person is having some of the issues that they are, because you can sort of see how they interact with others. It can be good as well. Countertransference also can be good if you find yourself really having some feelings that go beyond a therapeutic relationship. It's probably because of countertransference. And then if you get a little deeper in, which this is not on the exam, but if you get a little deeper in, the countertransference is really about your stuff. You know, it's really about how you're responding to whatever it is that the person is presenting as, or whatever it is you're ascribing to that. So your countertransference is really all about you and your issues or your beliefs, things that have happened to you in the past. All of that is coming together when you have a response or a reaction to them. So it can be good and it can be bad. But you have to be mindful of it always. Even if you're not doing half-hour or hour-long therapy sessions, you're just doing 15-minute med checks, there still is countertransference, and it can be useful. This, for object relations, there is some information that's good to know. I put this in the summary. And it is really, as most of what we use today is an offshoot from, it has its roots, even if they are deep, but it has its roots in psychoanalysis. And object relations was very close to, in the timeline and in its content, was very close to psychoanalytic therapy. So there is some information that's important to know here. Moving on to interpersonal, which again was Harry Stack Sullivan. He was practiced psychoanalysis, but developed his own theory, and interpersonal psychotherapy was born from that. So the major dynamisms, if you see the link, it really gives a nice outline of the next three subsections of what his theory contains. So these are the dynamisms: the malevolence, intimacy, lust, and system. And the personifications are here. The bad mother, good mother, the me personifications, eidetic personifications. And the levels of cognition. These three topics for Harry Stack Sullivan and interpersonal therapy, there are not a lot of questions on the last three slides. Levels of cognition, personifications, and the dynamisms. It is good to know, but you will not have a lot of questions on these. You probably should know what interpersonal therapy is good for, what is the usual course of time, psychoanalysis is years. CBT is like 8 to 12 weeks. So this is somewhere in between, depending on if it's an acute or a chronic issue for patients, but this is much shorter. So, psychoanalysis is the one that just is years and years and years. It takes a long, long time. That psychoanalysis is the one that that you think of the free association. The patients just they just start talking. The couch. Those are the types of things that you associate with psychoanalysis. Also the long time. And the key element to Sullivan's theory is the avoidance of anxiety, the reduction or the avoidance of anxiety. He thought that all behavior, he really was one of the forerunners in our current understanding of personality, but he really thought everything was in response to reducing or avoiding anxiety. And and our next slide is Peplau. She has a lot of contributions to mental health nursing. I mean, she basically established it separately as a type of nursing and advocated for it to be considered even with general nursing. So that was very important. These last few slides, I did not add any other information because it is very well outlined in the module. What I would suggest you do for understanding Peplau's model of the nurse-client relationship, those are highlighted the 4 steps are highlighted in the module. Be sure to know the 4 steps. Be sure to know exactly what they are and how you would apply them, at what phase of the relationship. Also understand that even if someone has been a patient of someone else, if they leave and you then begin seeing the client, it's brand new. So you're going to be, even though the client, they may have been in the termination phase, you're now going to be in the orientation phase. So it starts anew. And again with this, the therapeutic and non-therapeutic communication techniques, this goes way back to nursing school. Whenever you went to nursing school, this was probably harped on, and there is in the module a very nice outline of what those are. Things like validation, reflection, those techniques, what they are and when to use them are very important to know for this exam. So that is it for the slides. So I'm going to put this up. If there are questions, the exam will open on Friday at 7 a.m. and you will have until Monday at 11:59 to complete the exam. You have 1 hour to complete it. 50 questions, multiple choice. Pick the best answer. There may not be a very clear answer. Sometimes if you don't know an answer to a multiple choice, you will eliminate the ones you know are wrong. Well, you may not absolutely know are wrong, and maybe there is an answer that could be construed as correct, but there is a best answer. So be sure you're looking for the best answer. So please post questions, please email me with questions, and good luck.